I'm Josh Young, and I want to begin by thanking Gabby and Carl for giving me such a wonderful topic and the Ophthalmology Foundation for asking me to prepare this talk. Please photograph or get a screenshot of this slide. This is my contact info, my podcast, and an AI website. These are my disclosures. It is certainly far too late for us to discuss whether AI should be used by our residents. If there was to be any discussion whether our residents should use AI, that time has long since passed. I would like to start my presentation with a survey, and if you are watching this as a video, you may be able to see some of the previous survey answers. Let's put these concerns in perspective. I agree that the risks of AI are serious, but I will tell you that this conversation is not new. In Phaedrus 274 to 275 BC, Plato relates a story told by Socrates of a conversation between Thuth, the ibis-headed god, and Thamus, the god king of Egypt. Thuth, on the left of this slide, brought writing to man and extols the benefits of writing, saying that letters will, quote, make the Egyptians wiser and give them better memories. Thamus responds that, quote, this discovery of yours will create forgetfulness in the learners' souls because they will not use their memories. They will trust to the external written characters and not remember of themselves. In a sense, he was undoubtedly correct. The memorization of long tracts, which are fundamental to the pre-literate oral tradition, have indeed been lost. But I hope that we can all agree that written language was worth a trade. As an aside, Thamus also comments that, quote, the inventor of an art is not always the best judge of the utility or inutility of his own inventions to the users of themselves. Indeed, the inventors of frontier large language models really do not know how users will ultimately employ them. Even the transition from the scroll to the codex, that's to say a book with pages, was initially met with some degree of opposition. The codex was felt to be too informal, and even more criticism was lodged with the invention of the printing press. Erasmus, in his preface to the first edition of the Greek New Testament in 1516, bemoaned the ability of the printing press to rapidly disseminate typographical errors. Echoes of this concern for dissemination of incorrect information can be heard in our current concerns about hallucinations. And those of us of a certain age will remember concerns about the proliferation of calculators in public schools. This, by the way, is an article from 1965 complaining about calculators, and on the left side is what a calculator looked like of that same year. But calculators, the printing press, and indeed written language do hold some enduring benefits, and so does AI. In the late Pleistocene, when I was a medical student, we were expected to memorize a great deal more than we could. Medical knowledge has continued to blossom, and it is now literally impossible to memorize everything that is thrown at medical students and at residents. With the advent of AI, and particularly large language models, we can move from a model of memorization and information acquisition to one of knowledge management. AI now serves as an on-demand tutor that allows residents to explore in greater depth concepts that may not be completely spelled out in the primary literature. I asked ChatGPT to explain one of my favorite topics, which is the difference between trifocal and EDOF IOLs using modulation transfer function plots. It generated these plots de novo, and I have to say that they're really quite good. To the extent that I have any objection, it is that I typically put the defocus curve with its origin at 0 rather than at -4, but that is really a very minor point, and I think it handled the explanation quite nicely. In 1980, the esteemed science fiction author Arthur C. Clarke wrote about the idea of electronic tutors. I'm a professor, but I take no issue with Clarke's statement that any teacher who can be replaced by a machine should be. Perhaps a less confrontational way of putting this is that we, as teachers, should be doing what AI cannot. Truly, we are not in competition with the machine. AI is criticized in the popular press for its facility to produce deep fakes, but deep fakes are actually a wonderful tool for resident education. Image creation AIs can be used to produce deep fakes of retinal pathology. The newly generated retina images, like those shown here, need to be reviewed by experts, that's to say retinologists, to determine whether they are plausible and show the pathology of interest. This is really not any different from traditional image recognition for retinal photographs of actual patients. Genuine photographs also need to be reviewed by experts who label them as having the pathology of interest or of being controls. It is the labeling by experts that determines what we call ground truth. These experts can just as well create ground truth based on retinal deep fakes. If the images are not plausible, the experts will reject them. In the end, synthetic data may be generated that can be used to train image recognition models capable of recognizing rare conditions. These images can also be used for training residents to improve their own image recognition. I'm sure many of you have used Google's Notebook LM. It is a fantastic teaching tool that I myself use frequently. In this example, I've uploaded the BCSC chapter on intraocular lenses. Not to worry, I'm the author of this chapter, and so I'm not violating anyone's authorship rights in this example. After uploading, I hit the Generate Quiz button on the upper right-hand corner. And it did a rather admirable job. Then I decided to upload the entire bibliography, the literature search for this very lecture, and asked Notebook LM to produce its own lecture. I'm playing this video at high speed. I think the actual lecture is about 20 minutes long. Did it do a better job than I've done? I don't know. Maybe. But of course, despite these benefits and my framing things in a historical context, AI does pose some risks that are genuinely novel and specific to AI. In the 1950s, we were promised robots that would do household chores while we relax and zone out. But while relaxing and zoning out is acceptable when it comes to mowing the lawn, it is not a good idea in our professional lives. This is another little survey in which I'm asking the audience to name specific risks of AI in resident education. I've divided the risks into 4 types. I've listed cognitive risks first because I believe that they're the most important, but I'm going to save their discussion for last. Let's deal with technical and data risks first. We know that AI is susceptible to socioeconomic biases in the training data. Populations that are less studied will be underrepresented in the answers that AI gives. Also, by its nature, AI is trained upon old data, some of it older than others, and there's the risk of obsolescence of the knowledge that it presents. One problem that is not often brought up is biases that arise from the language of the source materials, and this turns out to be a very interesting subject. This is something that I discovered in discussion with ChatGPT about how it works at an algorithmic level. Large language models like ChatGPT are sometimes described as massive and glorified autocomplete algorithms. At its core, large language models divide your query, but not exactly word by word in the way that Google autocomplete does. Rather, it divides your query into what are called tokens. Tokens are typically about 4 characters long, but they can vary, and tokens will often split words. This is a tokenization example in which my question, consisting of 13 words, has been broken up into 15 tokens. Here I've given ChatGPT a query in Chinese, and it has tokenized this query. Chat will create its answers, its autocomplete, based on these tokens. It will autocomplete my Chinese query based on the Chinese text examples on which it was trained. Now, here's the interesting thing. The Chinese literature in the training data is not a translation of the English literature. It is a native Chinese literature. Also note that the ChatGPT did not translate my Chinese into English before tokenizing it. This means that if I ask a question in Chinese, the answer it will give will be based upon Chinese publications and websites and the like, not upon Chinese translation of English literature. But what if the Chinese clinical literature is different in content from the English clinical literature? If I ask a question in Chinese, will it give a substantively different answer? I'm sure you know there are all sorts of guardrails on large language models to prevent your using it as a physician, and there are ways to get around these guardrails. In order to get an answer, I presented ChatGLM, a Chinese large language model, with the clinical presentation as if I were using that presentation for an exam in order to prompt it to give me an answer. This is the question I gave, and these are the first 5 entries in its differential diagnosis. Now, I don't show this to critique the differential that ChatGLM is giving. I just want you to look at this differential. Then I use Google Translate to ask the identical query in Chinese, and you will note that the differential diagnosis is different. This is a result of the language-specific tokenization and autocompletion. Which differential diagnosis is correct? Maybe the English corpus of ophthalmic literature is larger than the Chinese, and maybe it's more giving a more appropriate differential? Maybe they're both correct. Maybe the Chinese differential diagnosis reflects the Chinese literature and is biased towards the Chinese patient population, and more reflects what an appropriate differential diagnosis would be for that population. I'm not passing judgment, but I am calling attention to the fact that the language in which you ask a question will influence the answer. This is especially important to the Ophthalmology Foundation that seeks to foster global educational outreach. Large language models have a tendency to make things up. I showed this case as an example of how broad the hallucinations can be. I have no real experience with drones and had just purchased an FPV drone for fun. I was having difficulty getting the drone to recognize my transmitter and asked ChatGPT what to do. I took a photo of the drone, and these are the instructions that Chat gave me. Chat instructed me to look for a bind button, and to make things easier for Chat, I uploaded a picture of the circuit board. Chat tried to describe very clearly what the button should look like and where it should be. And then to be extra helpful, it asked if I would like it to circle the button on my picture of the circuit board, and of course I said yes. Having shown me the button, I don't know how I could have missed it, and I was very grateful for this help. That is, until I compared it to the photo that I had uploaded. That's right, Chat had hallucinated a button into my circuit board. My point showing this is that hallucinations can extend to the visual and perhaps even to our clinical photographs. The answers that large language models give may hold so closely to the primary source material that incorporation of them may represent plagiarism. It is also important to note that the structure of the answers that large language models give may not adhere to the competency frameworks established by the American Academy of Ophthalmology and other organizations, and may represent a misalignment with our goals. The responses that large language models give often lack the scientific nuance of the original source material and can create an impression that is not supported by the literature. In this case, the original material stated that bariatric surgery was associated with a lower incidence of obesity-associated cancer. The large language model gave an answer that bariatric surgery is associated with a lower incidence of obesity-associated cancer. The original material was talking about data gathered in the study, whereas the LLM suggests some sort of absolute truth. But the most important risks, and those that will be the most difficult to address, are cognitive risks. These represent erosion of diagnostic reasoning, which can take the form of de-skilling, automation bias, and reduced metacognition. Why use AI at all? Can't we perform the same work ourselves? Of course we can, but AI is easier. It is easier because we delegate some of the cognitive tasks to the AI. We refer to this as cognitive offloading. But in doing so, some of our cognitive skills seem to atrophy. The most important recent example of this was a study of 1,400 colonoscopies. Gastroenterologists were assessed in their ability to detect adenomas on colonoscopy before introduction of AI, and then were assessed in their ability several months after the introduction of routine AI assistance for colonoscopy. They demonstrated a substantial decrease in their ability to detect adenomas. We refer to this as de-skilling. What can we do to address these risks? I represented to you at the beginning of this lecture that concerns about AI have cognates that date back literally thousands of years. The way to address these concerns dates back almost as long. Aristotle introduced the idea of metacognition, although it was not named as such until the 1970s. Metacognition is thinking about thinking, or examining how we ourselves or how another entity thinks. The great advances in large language models between ChatGPT 3.5 and the current iteration are attributable not only to larger training sets, but also to the incorporation of something called chain of thought reasoning. In early versions of Chat, one could obtain a more accurate answer by asking the large language model to divide its thought processes into a series of steps. This is a sort of metacognition in the sense that the LLM is forced to think about how it's going to think about the problem. We must teach our residents to do the same. Let's examine how we can employ metacognition in the way that we write prompts. The prompt on the left lacks metacognition. It's too general. It could apply to any setting. There's no patient context. There's no encouragement for the LLM to weigh alternatives, and it encourages laundry list learning. The metacognitive prompt will generate an answer that is not only more complete, but also more the way that a professor might answer, and it requests feedback from the resident to reinforce the learning. However, it's impractical for us to expect residents to write such beautiful prompts for every question. So let's examine the elements of a metacognitive prompt. We want first to establish context, either in terms of the patient or in terms of the relationship between the LLM and the student. We want to be very clear what we want from the LLM, and we want references to back things up. We also want to explicitly ask for counterfactuals. That is, we want to know what else things could be. If we're doing this in the context of an actual clinical setting, we may also want red flags. And as I said, we want to build in resident reflection. We can build a lot of this in by simply starting our conversation with the LLM with the information on this slide or something similar. Simply cut and paste this into the start of any conversation, and the effect will be a more educational experience for the resident. Let's see this at work. I've purposely selected an absolutely terrible prompt. I asked ChatGPT differential diagnosis for corneal edema. The answer it gives us is a laundry list. Here, I've prefaced the prompt with that little cut and paste that I showed you a couple of slides ago. It does indeed start out with the differential, although it does intermittently give its reasoning. Then it goes on to give counterfactuals in a way that an attending might do in a discussion with a resident. And it finishes the answer not only with references, but with an interactive exercise for the resident. Again, this is similar to the way that I would give an answer to one of my own residents, and I indeed would follow up my answer with a question for the resident herself. This is my last slide. I created a custom ChatGPT in which you can put a prompt and it will convert it to a metacognitive prompt and then grade itself according to the elements of metacognition. Again, I want to thank Carl and Gabby and all of the members of this panel.